Good day, ladies and gentlemen. This is a live recording of cryoablation with CBCT robotic assistant and the use of the HoloLens, recorded on the 29th of November 2021. The case is about a female 75 years old with an extensive cardiovascular history. She had poor cardiac function and a thoracic aortic aneurysm. Since 2015 there was a lesion in the upper pole of the right kidney of about 10 mm, where we decided for watchful waiting and first treat all the other pathology. On these successive CT scans you see the growth of the lesion from 2016 to 2021. And after the initial period of watchful waiting, we now feel we need to treat this lesion with percutaneous cryo and a general anesthesia, where we would also use 3 ice pearl needles. After arriving in the intervention room, the patient is put under general anesthesia, transferred to the intervention table in a prone position. We then install the base plate for the robot and attach the robot. Then we bring in the C-arm and we start with the preparations for the first CBCT acquisition. The planning CBCT acquisition is used for segmenting the tumor volume, for planning the different needles, and also for fusing it with the previously acquired conventional CT scan images. A final check is performed to make sure that the entire tumor volume is sufficiently covered and that the needles have a safe and proper trajectory. And then it's time to start preparing the patient. In this procedure we take care not just to cover the patient, but also cover the detector and the robot so that it can be used in the same sterile environment. A small disposable piece is used as the connector between the robot and the needles. After proper positioning the robot, we set the C-arm to the first entry point position and then we steer the robot in the desired position for entering with our first needle. For this procedure we decided on using 3 ice pearl needles, which are now being unpacked and then connected to the visual ice machine that controls the freezing process. In the testing phase, the needles are being tested by a short test cycle where we first warm up the needles and then do a short test freeze to make sure that there's no leakage of gas and that the needles are functioning properly. Then it's time to start the introduction of the first needle. The needle is inserted through the effector of the robot, and then a simple joystick control is used to bring the needle to its desired position. Positioning of the robot is very easily performed by just selecting translation and angulation and aligning the needle with the designated needle path. The progression of the needle is monitored by a 90 degrees perpendicular progression view that shows us the progression of the needle along the needle path in fluoroscopy. We then reposition the robot for the entry point for needle number 2, which is placed in exactly the same way as needle number 1. Again, we start by using the entry point view for verifying the entry point and making sure that our robot is aligned with this entry point. And for monitoring the progression of the needle along the needle path, the C-arm is then again moved to the 90 degrees perpendicular progression view position. Our third needle is placed exactly the same way as the previous two. After positioning the needles, a check cone beam CT is performed, and this cone beam CT shows that actually the neighboring colon is quite close, and we therefore decide to also perform additional gas dissection to protect this part of the colon. This is performed by inserting a very small 20 gauge needle connected to some tubing and a 60 cc syringe to control the amount of gas dissection. The amount of displacement of the organs is checked with fluoroscopy, and usually no more than 100 cc's of gas is necessary to provide proper insulation. Just before starting the freezing process, we always take a biopsy of the target lesion. This is done immediately before the freezing process to limit the risk of bleeding complications as much as possible. We then start the freezing process. In renal cryo, this consists of a double freeze technique that starts with a 10-minute freeze, followed by a 2-minute passive and a 4-minute active thaw, and again 10 minutes of freezing. At the end of the first freezing cycle, a verification cone beam CT is acquired. It very nicely shows you the extent of the ice formation around the needles and can be used for verification that sufficient coverage of the tumor volume is achieved. After the second freezing cycle, at the end of the procedure, usually 2 minutes of thawing is necessary to be able to remove the needles. The small skin incisions are then taken care of and small dressings are applied. The needles are disposed by cutting off the steel wires with a special plier. While still under general anesthesia, the patient is moved back to bed and then transported to recovery. The pressure on the visual ice machine is released through a special valve. Also at the end of the procedure, special care is taken for the mattress we use for supporting these patients during the entire length of the procedure. I thank you for your attention.